Asha, briefly about yesterday you were talking about training period and training programs and how do you go about it. So there is no formalized system here. Lekin what I'm talking about is what is recommended by ESGE, which is the European Society of Gastrointestinal Endoscopy. So to determine what is the ideal level of training or ideal period for training to become an ERCP, trained ERCPist, it is very difficult because there are very variable factors depending on the individual's aptitude for learning, the skill levels, and it's a very individual thing because everyone's hand-eye coordination is very different. So you have to tailor to that, but there are certain set standards which one has to follow. So generally speaking and most of this data has been taken from colonoscopy training program, that they find that training period of 12 months in a high volume center is usually appropriate. ये तो बिल्कुल ही चले गए तो हाँ 12 months ट्रेनिंग ये मतलब हमारे यहाँ वहाँ पे जो फेलोशिप्स होती हैं अच्छा चलो खैर इधर से ठीक है ये खफ हो गया यार जी जी मतलब लोग डिपेंड करता है लोकल उस पे ना जैसे यहाँ पे जो है ना दिस प्लेस जैसे वो हो गया डॉक्टर गयास का यूनिट हो गया ना मतलब दे आर इजीली मोर देन 1000 ना तो वहाँ पे भी हम एस्पायर करते हैं कि 1000 तक पहुँचे लेकिन मतलब जनरली 500-600 भी हो तो it is considered as a high वो ना
The individual ERCP is depends on how many people are doing ERCP in your center. So you should be doing ideally about 150 ERCPs a year.
अच्छा इसमें ये है कि during your training period जो आपका जो साल का या जो भी होगा one should be able to do about 300 level जब 300 वहाँ पे हमारे उसमें UK में 300 is considered as a level of competence पहले 200-250 होता था लेकिन 300 is now the standard ठीक है और उसमें ये होता है कि बेसिक रिक्वायरमेंट होती है 12 months की एडवांस ट्रेनिंग के लिए यू कैन हैव अनदर 12 months राइट तो ERCP ट्रेनिंग सेंटर में ये होता है कि basically when you are working there so you are not just doing ERCPs you are actively involved in MDTs pre and post ERCP cases imaging are discussed MDT का यही काम होता है कि before you do any case goes for ERCP हम लोग सारा बैठ के डिस्कस करते हैं कि ये ठीक है नहीं है उसके इमेजेस सारे चेक करते हैं ऑन्कोलॉजी की ज़रूरत हो तो देयर इज रेफरल टू एन ऑन्कोलॉजी सेंटर इंटरवेंशनल रेडियोलॉजी फैसिलिटीज शुड बी अवेलेबल टू यू फॉर एनी रैंडम प्रोसीजर्स और PTC और ट्रेनीज़ को एक्टिवली इन्वॉल्व करते हैं रिसर्च एक्टिविटी में ताकि वो पब्लिकेशन करें ट्रेनर्स अगेन जो आपके ट्रेनर्स होंगे वो मतलब दे शुड बी ऑल क्रेडिबल पीपल who should have at least 3 years experience of independent ERCP. Most of the time it's a lot more than that. 3 years minimum. Trainers should be performing adequate numbers themselves so that they are able to. Trainer's job is challenging and technically difficult as you could all see. And always remember ERCP is a high risk procedure and the trainers should have train the trainer course हम लोग UK में करते हैं इधर भी हमने शुरू किए हैं तो briefly क्योंकि this was part of my bigger lecture लेकिन I've really cut it down so difficult biliary cannulation is defined as more than 5 contacts with the papilla spending more than 5 minutes spent attempting to cannulate the papilla more than one unintended PD cannulation and again, most important, especially in the light and context of this course as well, trainer and trainee should have clear rules of engagement. When the trainer says stop, it means stop. ये नहीं कि नहीं जी छोड़ो जी मैं एक और करता हूँ ना ऐसे नहीं क्योंकि you are dealing with a live patient and it's a high risk procedure. So you might not realize, but the trainer might realize that he is in danger or he needs to intervene now. So that should be the discipline. There is, whenever we do these training programs, there should be formal assessment tools like the DOPS we use, and Khalid would be very familiar with TSAT. I have no idea what that means, but I think you people use the TSAT, US may? I don't know. I just took that from the literature. It basically just, the way we fill our DOPS forms, it highlights your trainee strengths and weaknesses, which is important. One should do it honestly so that you benefit from it. ASG recommend that trainees should have 20% of their procedures are set by TSAT. I don't know what's it. But in UK, we do it every 10 ERCPs. At the end of their training program, there is formative assessment and there is summative assessment. Summative assessment is the complete signing off. So that should be done at the end of the procedure, but of their training program, starting before they start independent practice. And it should include a review of their DOPS and also on live cases. Summative assessment is normally carried out by 2 independent trainers who are not that person's individual trainers. They should be other assessors outside. And after they pass that program, they should be monitored, they should be mentored for another 6 to 12 months, depending on their abilities. ये different levels हैं, मतलब you come across different levels of training in ERCP. Training steps, जो कि I think this is what this course aspires to. We are not doing any advanced levels here. So they should be able to do selective cannulation, extraction of stones greater than 10 millimeters, right? Treatment of bile leak after lap cholecystectomy, successful stenting of an extrahepatic biliary strictures. This is the basic level. Placement of pancreatic stents and needle knife pre-cut sphincterotomy. That should be part of your training as when you are doing your trainee program. Steps 3 and 4 are obviously advanced training that comes with more. So normally in this type of course, we do not encourage advanced training procedures because it's, you don't want to practice that at home. Just like when they tell you in these magic tricks or stunts, do not practice this at home. So don't do that at home. Send it to another center. Stenting a hilar obstruction, that's obviously a more advanced procedure. It shouldn't be attempted by early trainees or level 1 and 2 endoscopists. Removal of intrahepatic duct stones, they are again challenging procedures. Pancreatic therapy, ampulectomy, retrieval of internally migrated stents is always a pain in the backside. And ERCP in surgically altered anatomy after Billrod 2 or other bariatric procedures. Key performance indicator, what do we expect you to perform when you start independent practice? Selective native papillar cannulation of, this is for the people who have just recently been signed off, greater than 80%. After 1 year, our expectation is that, and there should be a stone clearance of greater than 85%. But after 1 year, we should be able to cannulate more than 90% of cases. Similarly, successful stenting of distal biliary strictures, which is non-hilar, in greater than 90% of cases after successful biliary cannulation, and overall post-ERCP pancreatitis rate of less than 10%. 10% is very generous. It should be less than 2 to 5%. On completion, prior to independent practice, ESGE recommends that a trainee can evidence a procedure volume of greater than 300 cases, native papillary cannulation of 80%, but 90% after a period of mentored independent practice, complete stone clearance, or is just a repetition of that. Thank you very much. Yeah.